Welcome back to part 2 of our discussion of mood disorders. Right now we're going to talk about bipolar disorders and related conditions. Remember again that we have to first talk about the different types of episodes individuals have, and once we determine the episodes, we can then fit them into the proper diagnosis. So first we're going to talk about a manic episode. For a manic episode, there is a significant period of time where the individual is abnormally, again, different from their norm, so it's an abnormal and a persistently elevated, expansive, or irritable mood. This has to last for at least 1 week and be present most of the day, nearly every single day during that full week. Some individuals could end up engaging behaviors that are so extreme or so dangerous that they end up being hospitalized. If they are hospitalized, they're likely to get medications, and those medications may get rid of their manic symptoms. So rather than saying, well, you didn't make it for a full week, so now you don't qualify for the diagnosis, if they have to be hospitalized because of the severity of their symptoms, then the duration of that 1 week is waived, and they would automatically count as having a manic episode. During a manic episode, we're typically looking at either manic mood or irritable mood. The manic mood is this elevated, expansive mood. It's not just that they feel good, it's an excessive, amazing, euphoric feel good. When people are in a manic state, people who know them recognize that it is different from their norm. But often just kind of walking down the street, being in different spaces, other people will recognize that this is expansive. This is beyond what we consider normal behavior in society. An example of this might be somebody who they feel so good, they're on top of the world, nothing can bring them down, they feel they can do anything, they're very, very confident, very, very excited about what they're doing and their abilities. But there are individuals who have a manic episode and their primary mood is irritability. So this irritable mood, again, is exaggerated, it's excessive. Will often come up as being overtly hostile. And examples could be yelling at strangers. They might have very little provocation and they hit somebody, gets over a fight over nothing, arguing with police over something inconsequential. But the irritability is far beyond what we would typically expect for that situation and for that person in their normal mood state. And on top of the manic mood or the expansive mood or the irritability mood, we look at other symptoms as well. And if they have that stereotypic kind of elevated expansive mood, we only need 3 additional symptoms. But if they only have that irritable mood, then the stakes are higher. We need to see at least 4 symptoms. And the reason for this is irritability is part of many other disorders. So we do not want to diagnose somebody as having manic episode if their irritability is better explained by another condition. Because some of these go in different conditions, we want to increase the symptoms to be certain we are seeing mania and not seeing a different disorder. These symptoms are probably going to look pretty similar. We've talked or hinted at some of them in the past, but one, inflated self-esteem or grandiosity, excessive confidence in their abilities, giving advice to others on topics that they really don't know anything about. They might feel invincible. They may even believe that they have some special relationship with very powerful people or with God or with the president. A decreased need for sleep. Remember what we said about insomnia. Somebody with insomnia is getting very little sleep and they're exhausted. Decreased need for sleep is somebody who's getting very little sleep, but they feel rested. They feel full of energy. They are raring to go. They may not have needed to sleep the entire week, and they still have this incredibly high level of energy. pressured speech, being very talkative. Again, we'd want to compare this. In my everyday life, I tend to be pretty talkative and I tend to talk pretty fast. So these would be those individuals who seem to have 100 words a minute. They seem to feel like they can't stop themselves from talking. They keep going, keep going, keep going. And this is often associated with the experience of having their ideas are racing through their head. We call this flights of idea or racing thoughts. So when they talk about their thoughts, they're talking about them going a mile a minute. They can't even keep up with their own thoughts. They're zooming past. Individuals are often very distractible in a manic episode. It's something that is completely unimportant, something that might be completely random, will completely derail them. So in the middle of the conversation, all of a sudden the humming of the heater stops them from what they were talking about, and now they're putting all their attention on that. Or they're talking about something and they see a leaf fall from a tree outside, and now they're completely derailed. An increase in goal-directed activity or psychomotor agitation. The psychomotor agitation could look very similar to what we've already talked about. Maybe they're flailing around, they're pacing up and down, they can't stop moving. But don't assume that the increase in goal-directed activities is consistent with what you or I might think is a good goal. I once worked with someone who, over a weekend, his goal-directed activity was to dig holes that were 6 feet across, 6 feet wide, and 6 feet deep, and he needed to dig 6 of these holes in that day. So that was a significant increase in goal-directed activity. He did accomplish that goal. He worked through the night, but most people would not agree that that was the kind of goal somebody should take on. And then excessive involvement in pleasurable activities or something that would be potentially painful or have painful consequences. This could be someone who goes on an unrestrained buying spree. They might have multiple random sex partners in a very small period of time. They might indulge in kind of purchasing some major item that wastes through or goes through their entire inheritance, and they just buy it impulsively. They might gamble. These are all things that we can anticipate something might go wrong, but because of this space that they're in, they do these things anyway, even though it might kind of lead to their ruin, and often can lead to ruin. And we expect that individuals would have marked impairment in their functioning, and we look at this in a number of different ways. One, we've already said. If they need to be hospitalized, we count that as marked impairment, even if it's less than the 7 days. But there may also be other significant impairment. Someone might end up having to declare bankruptcy because they spent everything or they gambled away their house. They may have relationship challenges. Perhaps something they did while in a manic episode leads to a divorce. We would also count it as significant impairment and count it as a manic episode if they have psychotic features. And this is a little bit different from many of the things we've talked about, because for it to count as a manic episode, we do not have to have the personal distress that we've talked about with so many of the other conditions. Because in a manic episode, while they're still in that space, they actually may not experience any personal distress. They may even feel better than they've ever felt in their whole life. So they are not in a position to judge whether they've had this marked impairment or whether it's significant distress, because the state that they're in prevents them from seeing that. And as with many of the disorders, we need to rule out other causes or potential causes. So it can't be related to the effect of another substance or a general medical condition. That's what GMC means. For example, hyperthyroidism could lead to symptoms that appear to be mania. And it's not at all uncommon. In fact, we see this 50 to even 60% of the time, where a manic episode might come just before or immediately after a major depressive episode without there being any time in between. Often people will have their first manic episode in their early 20s, but it has been known to occur after age 50 as well as in adolescence. And we do know that when it occurs with adolescents, it's likely to indicate a worse prognosis and to be associated with psychotic features at some point in time. One additional note, I already said this, but to drive the point home again, a manic episode that emerges during antidepressant treatment, so having electroconvulsive shock therapy or medication, antidepressant medication, would be sufficient evidence of a manic diagnosis or manic episode that would qualify them for a bipolar diagnosis. Again, I'm going to encourage you here to stop the video and watch the video of Mary on D2L. You've already seen the video of Mary in a depressive episode with psychotic features. Now you're going to see Mary the next day, but now she's in a manic episode with psychotic features. So again, this is an inpatient sample, so it's far more severe. The presence of psychosis is not common, not common for kind of everyday people, but it gives you an idea of the full range of severity of symptoms that are possible with this condition. The next type of manic episode we might look at is a hypomanic episode, and some will think of this as a mini mania. So here we see elevated, expansive, or irritable mood once again, and we might see abnormally and persistently increased activity and energy. But it lasts for 4 days, as opposed to needing to make that full 7 days that are required for mania. And we look for at least 3 of the symptoms of mania that we talked about earlier. And these symptoms are the same as those for a manic episode, but they are more mild, even though it does show a change in functioning that others might notice. The episode is not severe enough to cause marked impairment or hospitalization. And this just makes sense. A hospitalization, even if it's only day 1, is significant enough that it would count as a manic episode. So this has to be less severe, and it cannot require hospitalization, because if it did, it would jump it to a manic episode. And a hypomanic episode cannot have any psychotic symptoms to count. If there's psychotic symptoms, we're not looking at hypomania. Hypomania, by definition, is much more mild. It's often shorter, no impairment, no significant impairment, even though others might see the change. And 5 to 15% of those with hypomania do indeed eventually go on to have a manic episode. So having hypomanic episodes does not mean it will always be that way, but for the vast majority, they will have hypomanic episodes and never move into full-blown manic episodes. And one question I often get is, how does this differ from ADHD? The person is, moving around a lot, they get distracted, it's much more mild than mania. How might this look similar to ADHD? And if you looked at a one given moment, it could actually look very similar. But if you look over time, it is very, very different. For example, ADHD typically has a very early onset, at least 7 years. ADHD is also chronic. It doesn't come in episodes. This is how that individual is and how they experience the world every day, most of the day. People with ADHD do not typically have an abnormally expansive or elevated mood. In fact, sometimes they have some negative thoughts and beliefs, because the things that come with ADHD have traditionally gotten other people mad with them. And you won't see kind of a clear start and stop with ADHD. They're symptomatic pretty much all the time. Someone with a hypomanic episode, they're typically not going to have an onset until adulthood. It shows up in these short periods of times where you could clearly show when it starts and stops, and then it goes away. They do tend to have the elevated expansive mood in contrast to ADHD. So there's lots of things that make it look very different if you understand the history the individual has with their symptoms, which is part of what, as a psychologist, we would be doing if we're assessing someone. Remember again that when we're looking at the mood disorders, we need to figure out the episodes that they have now, figure out the episodes they've ever had, and then we put these into the proper diagnoses. In the past, all of the bipolar related conditions were in mood disorders, but now they've been separated. So we have mood disorders in the DSM. After that, you see the bipolar and related disorders, and after those, you see the psychotic disorders. And this was intentional. Even though the disorders themselves haven't changed much in their definitions, they wanted to break them apart and put bipolar disorders between depressive disorders and psychotic disorders as a way of representing that they seem to be a kind of bridge between these two categories as far as the symptoms, genetic relationships, and the family history. So they're really the same as mood disorders or the same as psychotic disorders, but represent a space in between the two. Our first condition, bipolar I. The essential feature here is that they have a history of having at least one manic episode. At least one full-blown manic episode. They may have also had hypomanic episodes. They may have also had depressive episodes, but they don't have to have had either for the diagnosis. And this is sometimes confusing to people because unipolar depression is our traditional depressive disorders. And if you think about it as a pole, unipolar means they're at one end of the pole, the depressive end. Bipolar traditionally is conceptualized as being both manic and depressive. In fact, we used to refer to it as manic depressive. And bipolar implies that they have times where they're at the one pole, the depressive pole, and then they have times when they're at the other pole, the manic pole. What's important for you to remember is that even though it's called bipolar, it does not necessarily mean that they experience both sides of that pole. What they must have is the manic end, but they may or may not have the depressive end. That said, it is most common to have both mania and depressive symptoms, and about 60% of those with manic episodes will occur immediately after having had a depressive episode. Individuals who have bipolar I disorder do have a fairly high rate of having having psychosis. And when individuals have psychosis, they're likely to have a poorer outcome. And by a poorer outcome, I mean they're more likely, if they have psychotic symptoms in this episode, they're more likely to have psychotic symptoms in a future episode. And they're more likely to have incomplete recovery between episodes. And although only one manic episode is required for the diagnosis, over 90% will indeed have multiple episodes over the course of their life. In fact, the modal number is that if somebody has a manic episode at all, the modal number is 4 episodes in a 10-year period. Some things about the episodes though. When we're talking about episodes, this does not necessarily mean manic episodes. It could be manic episodes or depressive episodes. And if you think about a 10-year time frame, that actually implies that for most of the time in that 10 years, they are doing well. Not the stereotypic image of bipolar disorder that we might see on TV or on movies. They often are not symptomatic all the time. And in fact, up to 80% have full recovery between their episodes. So they might have a manic episode and it lasts for a month, and they're fine for years, and then have a depressive episode. That might last for a few months and immediately go into another manic episode. And then they may be asymptomatic for another 5 or 6 years and then have another episode. So we have to remember that the vast majority of the time, people with bipolar I disorder are actually functioning well, even though it is a serious condition that does require significant attention to manage symptoms. One particularly severe group is the group that we would refer to as rapid cycling. Thankfully, this is a small percentage. Only 5 to 10% of those with bipolar disorder will have rapid cycling, but this is particularly severe. Remember, we talked about the modal number is having 4 episodes across 10 years. Rapid cycling cases have 4 episodes within a single year. Extrapolate that to 10 years, whereas most people will only have 4 episodes in 10 years. Those with rapid cycling will have 40 episodes in that same 10-year period of time. Unfortunately, rapid cycling also is less responsive to our standard treatment, which makes this group at particularly high risk. And when we're talking about bipolar disorder, their risk of completing suicide. When I say completing suicide, that's those who successfully end their life through suicide. So many people might have thoughts of suicide. They might attempt suicide. These are the individuals that will die by suicide. There is a 15 times higher rate of completing suicide compared to the general population among those that have bipolar disorder. And this ends up accounting for over 25% of all completed suicides. So extremely high-risk population for suicide. The next condition is bipolar II disorder. And the key distinction here is that they have hypomanic episodes, not manic episodes. So they have at least one hypomanic episode, and they have at least one full major depressive episode, which is different. In bipolar I, they did not have to have a depressive episode, but hypomanic episodes, because they can be so much less severe, we need to be certain what we're looking at. So we require a full major depressive episode and a full hypomanic episode in order to qualify for bipolar II disorder. And of course, they can never have had mixed episodes or manic episodes, full-blown manic episodes. Let's talk a little bit about the prevalence of bipolar I versus bipolar II. Bipolar I, this is where they have full-blown manic episodes, and they may or may not have had depressive episodes. This can be anywhere from roughly 0.5% to 1.5% of the population. Bipolar II is only about 0.5% of the population. I want to also add that these are probably looking at slightly different populations, because for bipolar I, we're also going to be seeing hospitalized samples, which would have higher rates. But bipolar II cannot have required hospitalization. So these are community samples that would be demonstrating bipolar II disorder. As far as sex ratio, we see similar rates for men and women for bipolar I disorder. But there's an interesting phenomenon for bipolar II where we see slightly more women qualify for bipolar II compared to men. And unfortunately, there aren't good studies that give us information about other genders, intersex people, or other non-binary people. There are also interesting, let me go back and say another piece. It's important that slightly more women have bipolar II because bipolar II is a less severe condition. There are also trends where men are more likely to have their first experience be a manic episode, where women are more likely to have a depressive episode be first. And if they have bipolar disorder, they're more likely to have another episode postpartum. And if their first episodes include psychosis, they're more likely to also have postpartum psychosis when they have a postpartum bipolar episode. And this is important because we have these images of postpartum depression and postpartum psychosis as almost anyone who has a pregnancy is at risk for also having postpartum depression. And it turns out that's not true. Women with a past history of depression are more likely to have postpartum depression, and women with a past history of bipolar disorder with psychosis are more likely to have postpartum bipolar episodes with psychosis. The age of onset also differs for bipolar I versus bipolar II. Bipolar I, the onset is typically 18, but bipolar II, the onset is usually 22. This goes back with other things that we already said. Bipolar I is more severe than bipolar II, and it is common that more severe versions of a disorder also often show up earlier than is normal. So it makes sense that the less severe version, bipolar II, shows up a little bit later in life. We also know that it's extremely rare for children to have bipolar disorder and for individuals that have never had it to suddenly have it at age 40. In fact, if somebody does have bipolar episodes or qualifies for bipolar disorder after age 40, it's far more likely to be the result of a general medical condition or some kind of medication rather than truly being bipolar disorder. The onset tends to be acute, meaning it just kind of all of a sudden shows up there. And it is chronic in that individuals do need to kind of be actively managing these symptoms for the rest of their life, but it's in episodes. They're not experiencing the symptoms constantly. They have a period of time with an episode, then they're better. And then another period of time with an episode, and then they're better. And these times between episodes can be years and years long. The last condition that we're going to talk about in this category is cyclothymic disorder. And you might remember we talked about dysthymic disorder, and that was the disorder where they had a low, mild depression, but the depression was very long-standing for at least 2 years without getting better, and 1 year for kids. The trick is when you see that thyme, think time. So dysthymia is the long-standing time. Cyclothymia is similarly a long-standing time frame. Here, individuals will have these symptoms persistently for at least a 2-year time frame. And again, for children, we only count 1 year. And during that 2 years, they are consistently experiencing hypomanic symptoms and depressive symptoms that don't meet full duration and severity or pervasiveness requirements for a manic episode or a major depressive episode. So they're continually having these hypomanic symptoms and these depressive symptoms, but they don't meet the full criteria. Similarly as dysthymia, they cannot be better or symptom-free for a full 2 months. And if they do have a 2-month period of time where their symptoms are gone, we would have to restart the clock if they start having symptoms again in order to get to that full 2-year period. So just to drive home the point, This means they've had no major depressive episodes, no manic episodes, no mixed episodes during this entire 2-year period of time. We see cyclothymic disorder in less than 1% of the total population. If we were to look at those that are in a mood disorder clinic population, it's a bit higher. We'll see that anywhere from 3 to 5% of individuals at a mood disorder clinic are there because of cyclothymic disorder. It is equally common in men and in women, and there is a proportion of these individuals that later go on to develop either bipolar I or bipolar II disorder. Estimates have been anywhere from 15% as high as 50% will eventually go on to develop bipolar I or II. This is the end of our mood disorders lecture. If you haven't already done so, be sure to go watch the videos on D2L. You'll see Mary, who is the next day from her first interview and is now in a manic episode with psychosis. At the very least, make sure you watch that one, and I will see you next as we talk about suicide.